next session will be the last live session. We have distinguished panelists, Jung-Min Ahn, my colleague, Tse-Min, Tae-Hyun, Won Kim, Tanyarat, Aramsareewong, and Jin-Man, Myeong-Ho, Yoon, and myself. I think we can start the session. Okay, please, the first case.
Okay, I'm very happy to see you, Professor In and Michael and many the key faculty as our panelists. And so today's session, in the 1 hour, we're going to show the 3 last complex case chip procedure. I'm D.W. Park, and my first assistant is Professor Jun-Hyun Kim. He is now is a professor at the Korea National University, and our fellow is Dr. Kyung-Won Seo. Okay, Dr. Seo, can you present patient background?
Yes, thank you for your introduction. I'm Kyung-Won Seo. I will introduce this case. A 61-year-old male was referred for dyspnea insertion. He has been treated with hypertension and dyslipidemia. Next. Clinical presentation was stable in China. Next. Electrocardiogram shows normal sinus rhythm. Next. There was no cardiomegaly and pulmonary edema. Next. Echocardiography shows normal every systolic function without regional wall motion abnormality, and treadmill test was positive. Thallium SPECT shows reversible large size perfusion defect in mid-anterior and apical inferior wall. Next. Baseline coronary angiography shows diffuse heavy calcified stenotic lesion in proximal to distal LCA. Next. And heavy calcified stenotic lesion also in proximal LAD. Next. So we are allowed to perform a PCI at RCA using DES. Next. So target lesion is proximal to mid-LAD, and we planned OCT guidance PCI, and we will use rotational atherectomy.
Okay, and could you back up the previous slide? And the RCA, looking at the before, the RCA region, initially we think about the balloon is passed well, but any balloon does not pass even 1.0, and that time, and we performed the rotablation, and then we put the 2 drug-eluting stents. So, angiographically not severe, but it's any small size balloon does not pass, and underwent rotablation, and then the successful PCI for RCA region. Today, could you show us today coronary angio? Okay, so, and looking at this is area caudal view. I think a suck is okay. OM branch is small. Just I would like mainly target the proximate LAD, and you can see thallium scan shows positive LAD territory, and there is a very tight region, and you can see the very severe calcification. And next one. So, and this is the area cranial view is very difficult to find. Very nice coronary angiogram showing the exact the length and location. And this is area cranial view. You can see very tight the prox LAD, and the region was extended to the mid LAD. And next one. So, and this is the epicranial view as well, and you can see very severe calcified region. By definition, not much severe, but absolutely there is some calcification in prox LAD. And next one. So this is the cranial view. It's difficult to differentiate LAD and circumference. And next one. This is spiral view. And next one. So, and we're gonna try to do any balloon did not perform, and we try to do OCT pre-evaluation does not pass well. So next one. So, and we try to pass this is a 2.5 non-compliant balloon, absolutely non-compliant balloon 2.5 does not pass. And next one. So we exchanged smallest NC balloon is a 2.0. 2.0 balloon does not pass at the moment of the very severe calcified region. So as you like at this moment, and we're gonna discuss how would you like to treat this patient. Could you show us baseline angio? So the pre-OCT evaluation does not pass, and the 2.5 does not pass, and 2.0 did not pass, and so Michael and Dr. Ying, and I would like to hear comment at this stage.
Hi, Duk-Woo.
Yeah.
The first thing is trying to find a view which lays out the lesion best. You try the LAO cranial, AP cranial, and RAO cranial. How steep did you go for the AP cranial? Did you go at least 40 cranial?
We are using a 7 French XB 3.5 guider.
Great. Can you tell us
꺼진 것 같은데,
how
지금?
steep cranial you are at right now? What degrees? 43? Okay. I think this is about the best you can do. I think this is going to be a relatively straightforward procedure. I
Yeah, the
think
cranial view is
오케이. 너무 커, 너무 커. 여기 누가 들어와서 좀 빨리 대달라고 그래.
You can see it from the screen, 43.
RAO is 19 degrees.
I think this is a very straightforward case. I think if you start off with a 1.5 burr, you should easily get through with adequate plaque modification and then proceed forward with definitive treatment.
소리 다 노이즈, 전부 노이즈.
I think for this uncrossable lesion, rotablation is a better option.
주연이 들려?
노이즈 있는 채로 들려.
Dr. Pa, what size of burr would you choose?
What do you think about using guide extension like guide Jilla before the rotablation?
The burr size is 1.5.
1.5. So, and 2.0 and 2.5, any non-compliant balloon does not pass, and we are prepared. The rotablation is 1.5. So, at this moment, there is no option. Any balloon does not pass, and for this case, and the IVL does not pass well, absolutely. And so IVL, the sizing is similar to the cutting balloon. So, and at this moment, we consider orbital atherectomy or rotablation. So we select rotablation. So we're gonna do technical team 체크하고 있어?
Dr. Pa, will you try to use extension guest to assist rotablation?
좀 low speed지?
Yeah, we are not using any extension sheets, just
자, 들어가보자.
rotablation.
지금 오케이, 들어갈게. 뒤에 잡아. 자, 뒤에. 잠깐만. 뭐가 딱 물고 있어, 와이어를. 자, 됐어. 자, 들어갈게. 로우 스피드. 이거 테크니컬 팀 빨리 손 봐야 되겠다. 말씀하시는 게 하나도 안 들려. 와이어 잘 잡고. 네, this is a 1.5. 오케이, 됐지? 자, 됐고. 자,
하이스피드 셔는
잠깐만. 딱 됐지? 오케이.
What speed do you use?
This is more than 180,000. Okay, good. Okay. 자, 조금만 기다려. Yes. We will wait.
Duk-Woo, is your assistant giving saline flushes during your runs?
Okay. So we try to do one more. In the 1.5 cutting, 1.5 rotablation is test well. This is the body beat motion. Okay. 자, 떨어지게. 오케이. 자, 저장하고. 자, 한 번만 더 하자. 조금만 기다렸다가. 오케이. blood pressure is okay. 소리 들리면 얘기 좀 해줘.
저도 아무것도
안
안
들려?
들려요.
오케이. And
This kind of polishing runs, usually in Zhenqing Hospital, we are practicing with Dr. Yin.
됐어.
We're using each time 10,000 speed
Okay, we
lower.
applied 3 times.
Then
rotation.
each time we
This
just
is low
debugging
speed.
10 to 15, but slow moving. Just try to debug at the most calcified portion. That can be increased, that debugging area of about 20 to 30%. That is, we adapted from Sapporo Heart Center.
스트레이트하게 해줘야지. 뒤로 좀 가고. 오케이. 자, 이제 빠지면 안 돼요. 오케이. 에이. 마이크로 카스터 저거 다 빠졌다. 그냥 줘. 자, 그냥 와야죠. 시험블루 위에. 지금 테크니컬 팀 손 보고 있어?
네, 보고 있습니다.
It's okay. Already channeled.
테스트. 테스트. 오케이. Okay, wire was passed well. We're here. So at the angel here. Okay. Good. I think it's much better. So at this moment, I'm gonna check OCT. Okay. Can you hear me well?
Yeah, very well.
Okay, okay.
I think the vessel is big. Do you think
yeah.
1.5 is enough?
Yes, I think 1.5 is a ball was passed well at this moment. I'd like to check it up the OCT, and then I'm gonna apply to the high pressure NC balloon. Okay, got it.
Because right now, if you're
Okay,
using
good.
rota cutting or rota high pressure, the burr to arterial ratio maybe like to achieve at least 0.5, maybe 0.6. Try to debug as much as possible. But if you're using maybe rota tripsy, you can be somewhat relative conservative.
2.5 NC 줘봐. So, and the OCT wire is passed well, and you can see how much calcium over there. This is a distal reference part, and the vessel size is 3.0, and this is some calcium. You can see absolutely 9 o'clock, as there is a huge calcium, and I think there is some crack. Okay, and could you show us the much smallest part? Okay, here is you can see there is some the crack of the calcium. Okay, here. This is a 2.5. 뒤로 좀 당겨봐. 2.5. NC balloon이지?
Well, that is always a concern regarding inadequate debugging. How do the panelists think? Is that enough, or should we do further?
Dr. Lu? A lot of experience of calcium.
Yes, probably we can see the OCT again for the minimal lumen area. Because there looks like some, we cannot clearly see the thickness of the calcium. So if the calcium is still very thick, probably we need another operation.
Okay, deplete. This is a 2.5. NC balloon 20.
20.
Okay. Deplete. I think the lumen was expanded well. Okay, 20. 24.
24.
Okay, deplete. 24. Okay, 26.
26.
Okay, deplete.
It looks not so well expanded.
자, go. 20.
20.
Okay. Deplete. 자, 24. 25. 26.
26.
Okay, deplete. 자, okay, I'm gonna check it up here. Shot.
Any one of you will consider cutting balloon? Or?
Yeah,
So, yeah.
because I think that the
Seems
NC
that
balloon
yeah,
did not
still inadequate expansion.
저 앞에는 얼마야? 3.5의 NC balloon? Additional NC balloon gonna apply the. 그러면 얼마? 그 앞에 한 3.5 줘봐. 3.5 NC balloon. Yeah. we're going to apply the 3.5 and the proximal part, and then reevaluation the OCT. So it's a good thing is after rotabulation and the NC balloon is expanded where the mid and distal part, we are now targeting the proximal LED part. Is how much delay to the NC balloon. This is a 3.5 NC balloon.
Good things is because this is 360 degree of calcium, so I think high pressure optimal size would be you can create some cracking. We'll see after high pressure and OCT.
Yeah, I have a question. At this, if in your experience, do you have experience after rotabulation and then applying the IVL?
Of course, Deng have a lot.
Sure,
Dr.
we
Yin
did
can
a lot.
answer.
Yeah, Esther? You did a lot. Okay,
Yeah,
Esther?
and that's a very good combination.
10, 14, 16. As you can see, the deplete expanded
much
well.
better.
Yeah,
This time,
much better.
much better.
자, go. 10, 12, 14, 16. This is 3.5, 18, 20. Okay, deplete. 자, go. 10, 12, 14. Okay, I think the region is expanded well. Deplete.
I think this is a good example of how you use a
you're ready?
non-compliant balloon and it profiled normally and well, therefore you do not
Then check
need
it up, OCT.
IVL or cutting balloon. I think the litmus test is a non-compliant balloon, and this shows that you don't need to use it.
Also, and the one lessons we can the lesson from the recent orbital atherectomy trial, Eclipse trial, there was shows the conventional the rota and the angioplasty is equal, absolutely suitable, the comparable to the orbital atherectomy. So like this, and the small balloon does not pass, you can apply the rotabulation, and then you apply the high pressure sequential NC balloon, you can achieve the sufficient the lumen expansion. There is one lesson from-
Regarding the Eclipse trial, I think that's accumulates too long to enrollment, and also each operator only doing a limited case. So
Yeah.
indicates that
여기
every
다
case
들어간
is not imaging
여기까지만
guided,
들어가면
also
되죠?
not
Yeah, okay.
experienced hand. So what do you think, commentary, Michael, if you are thinking Eclipse
Okay,
negative,
Prussia.
you think orbital doesn't work,
Okay, good.
or maybe you are experienced and you can do better?
Yeah, we
Bobby.
actually were a clinical site for that. We enrolled patients in which we thought that orbital
3.5
atherectomy
도 되겠다.
or balloon angioplasty would be clinical equipoise. If it's a long diffuse lesion, where in this case, for example, that the
VT
balloon
style,
didn't cross,
그 정도?
these patients were not enrolled into the trial. So this,
Okay.
when you selectively with image guidance, I think about 67% had image guidance. If you could fully expand the balloon, do a good job, you could get good results. I don't think it's required, but if you can't cross the balloon in this case, this is where you need atherectomy.
So, and this is the long segment evaluation OCT, just one shot. You can see that there is crack and the expanded well, some calcified region. And here is proximal segment we're gonna target. Okay, and we should cover over here. 여기도까지 crack도 있고, 그지?
Dr. Liu is
proximal,
satisfied of
yeah.
POCT
한 요 정도?
after
너무 앞으로
operation?
나오는 거야?
Dr. Liu,
조금 요 전에, okay?
are you satisfied about this image?
Yeah, sure.
Lesion
Since there's
preparation.
many crack.
Seems that
Explain well.
Many
lesion
crack.
being prepared very well.
So, and the distal part EM size. So, I think 3.5 would be okay. Length 34. 그러면 우리가 뭐 넣기로 했죠? Okay, 34 is okay? Okay, good. 34 주세요. 34 resolute 3.5. 3.5 resolute.
Yeah, I think you did a great job with atherectomy followed by high pressure balloon inflation. This case is going very well, and you should have an outstanding result.
So,
So,
and the
Michael,
still-
in
and
the US, will you use high pressure balloon only, or will you do IVL before?
I mean, I think cost effectiveness wise, there's no benefit with IVL if you do adequate plaque modification. You look at all the studies with, let's say, orbital orbit 2 or rotation atherectomy, they do fine even in the pre-IBL era.
앞에 맞는 것 같아, 그지?
네, 코다람
디지털 파드 is okay. 오케이. 자, 테스트. 오케이, 앞에도 굿 좋고.
The diagonal
오케이,
need to
테스트.
protect
Yeah, please.
So I think it is usually okay. Okay, test.
Tanyarat is asking is wire protection for the diagonal is necessary or not?
So
EW.
I think the ostium of the diagonal branch is wide open. Okay, deflate 3.5, 그지?
네.
얼마까지 갔어? 12. Okay. So test. So. Okay, so I'm gonna apply the NC balloon 3.5. So, and looking at the diagonal branch in the ostium, it looks like a very narrow and the narrow angle. We apply the wire, but this patient is very wide open, the diagonal branch, and so I, just omit the diagonal branch wire protection. That is based on our experience. I make sure that diagonal branch do not close. Okay, this is a 3.5.
Dr. Ba,
Yes.
this is Myeong-Ho, and before the rotabulation, NC balloon is very difficult to passing the tight region. I think if routine balloon, so
Okay.
smaller routine balloon can be passed the first before
Yes.
before first region. How
Okay,
about you think
14.
if in the absence of the rotabulator?
So I think is a 2.0 NC balloon is inflated well.
Routine
And then
routine smaller balloon.
No, it's just the 2.5. Initially, my attempt is to put the 2.5 NC balloon, but did not pass. So I select much smallest NC balloon is 2.0. That did not pass. So I'm decided to use the rotabulation. If 2.0 work, and then we are step up reverse. Okay, go 10, 12, 14, 16. Okay, deplete. I think expanded well. 자, go 20. As you can see, there is very expanded well. Deplete. 자, go 20. Okay, deplete. 자, 24. Wait, 기다려. Okay, deplete. 자, last, one more. 자, go, 20. Okay, 24. Okay, deplete. So I'd like to give some nitro and then the check angio and then check final OCT. So, and unfortunately in the South Korea, we're not available IVL. We have a next time opportunity. We're gonna use the IVL and orbital atherectomy, and that will be also good option. Okay, angio.
ready.
Good. So I will check the OCT and the side branch. Ostium is okay, and so I will check it up the OCT. So, and especially for complex region, OCT I frequently use for ISR region, also some calcified region. This is very useful to evaluation the amount of calcium and the characteristics of ISR region. Okay. 이렇게 해놓고 테스트 살짝. 오케이, 자 준비됐지? Everybody ready? Okay. 자, 풀샷. Okay.
Very nice.
Yes. So we will show the OCT finding is very clear, and if you use the guiding caster without sidewall, you can achieve the very nice view. Here is the distal edge is no in a position, is a fully expanded well. Okay. So, and this is expanded well, and that was a prior calcium region and expanded well. Okay, good. And there is some calcified part, slightly some inner position part. Usually that is okay. There was a very severe calcified region over here, expanded well, prior calcium. And the proximal part a little bit inner position. And could you show us proximal edge? So I think that would be okay. And if you attach that one, we need the additional the 4.0 balloon. I think it is such in a position, the clinical impacts just a little, and I think the final result is good. So any further comment for this case?
Excellent.
So as you showing us, we don't need Avio in this case, actually.
And you save $5,000. That's a good thing.
Yeah. I save cost of the IVF.
Another masterful case. Thank you, Duk-Woo.
Thank you.
Thank you. Excellent.
Thank you.
Congratulations.
요 딴들 보고.
Okay, the second case will be introduced by Dr. Woo. Yeah.
Good afternoon. This is Jung-Min. So we prepared another very calcified diffuse complex PCI cases. So I'd like to introduce my teams. Dr. Han-Soo Park is our senior fellow. Will introduce the patient, the brief history. I'm doing the procedure, and then.
Okay. I introduce this case. This case is 71-year-old male. He have typical chest pain. He has been treated with hypertension and diabetes. Next. And his clinical presentation is stable angina. Next. ECG showed normal sinus rhythm and no significant STT segment change. And next. Chest X-ray showed no significant finding. Next. Echocardiography showed hypokinesia of anteroseptal wall motion, and global LV function was preserved. Next. In coronary angiography, in right coronary artery, there were diffuse heavy calcified plaque and diffuse stenotic lesion at the PDA. And in caudal view, we can see the diffuse heavy calcified region and distal at the distal left circumflex artery. Next. In cranial view, we can see the ostium region of the left main and diffuse heavy calcified stenosis along the extended to the mid LAD. Next. Yes. Target vessel is left main and to mid LAD, and we plan the IVUS guidance PCI and calcium preparation will be done with the rotor atherectomy.
Could you show us the initial angiogram, please? So look at there is some paleness of left main ostium. At the initial coronary angiogram, we didn't see any stenosis of left main ostium, but when you engage this is the A-French jockeying guiding catheter, we engage the guiding catheter to the left main ostium, the pressure damped. So definitely left main ostium, there is something wrong. Next, please. This is not stent. Actually, this is calcification. Yeah. So this is not instant restenosis, just diffuse calcified lesion. So from the beginning, we decided to do some rotablation. After insert to the rotor wire. Next, please. Next, please. So we try to insert the IVUS catheters, failed to pass the IVUS catheters. So this is so decide to do rotablation. This is 1.5, the rotor.
And it's a floppy wire or extra support wire?
Extra support wire. Then next. So after the rotablation, this IVUS catheter, it passes through the distal lesion. This is my personal successful sign of successful rotablation. So if I can pass through the IVUS catheters, then I think it is successful.
So you try
after-
to disengage the guiding from the left main osteo after
Yeah,
IVUS
because-
passing. Okay.
Yeah, so could you show us the IVUS? Yeah, this is just the mid LAD. So from here, you can see the very diffuse, calcified, very long atherosclerotic LAD disease. Calcium is encircled almost 360 degrees.
See some reverberation.
Yeah.
Indicates of debarking some calcium.
So some breakage of, you can see that some breakage of ring calcium. So it looks like the diagonal branch, but diagonal branch is already the very diffuse disease, the distal part of diagonal branch. So I don't like to insert wire to diagonal branch. Here is a proximal LAD and insert the calcification as well.
Anyone want to do a more debarking instead of 1.5, then with high pressure? Dr. Lu, you want it to be increased, or maybe you can think this is enough debarking?
Yeah, I think from this IVUS imagery, I think there's so long circular calcification. So, and with many reverberation, probably the calcium is very thick. So maybe I can choose the larger burn, at least the 1.75 or using the cutting paddle.
Or the escalation of the rotor speed.
Yeah, sure.
Yeah,
We'll try the high speed and low speed.
Yeah, that would be a good opinion. I do good advice. So here is a circumflex. Here is left main. My concern is left main ostium. Left main is also lumen is big, but here is ostium. Very elliptical lumen. Here is very ostium.
So any tip and trick, Dr. Lu, regarding the left main osteo debarking? You want to use a wire bias or use a extra support wire, try to debark some? Orbital may be better, but because now we don't have orbital here.
Yeah, from the imagery, first it looks like the wire bias is not so good, especially in the left main osteo. So probably during the abrasion, maybe we can adjust the guiding position, pull out a little bit, and change the wire bias. Try to make more debarking. Yeah.
So personally, I think the lumen is maintained. In this case, I don't like to do more debarking.
Tanyarat, you have orbital in Thailand, so maybe you can comment regarding osteo left main.
We don't have orbital, haven't been yet. Maybe next year.
Maybe next year.
But I have one question. To consider this case, LVD is quite very small and long calcification. Are you consider the duct-coated balloon without stent? Because stent is probably high risk for restenosis.
If we can achieve greater lesion preparation, for example, you have imaging guided and you have debarking, cutting, have cerebral cracking without severe dissection, type C, type D, might be DCB is another option, of course. Yeah.
Is this a 3048?
No, this is 2548. 9. So fortunately, stent is well expanded. Oh, I missed another procedure, deflation.
Yeah, usually
So
before stenting, we do a high pressure.
Yes, I missed that. During the Dr. Bart explained the history, I already did the high pressure balloon dilatation using 2.5 high pressure balloon. There's just some indentation, and next, more high pressure up to 28. Next, and then because we have one more live demonstration, so I don't have enough time. 10. 12, 14. So fortunately, the stand is very well expanded, deflation. So measuring the remaining
Dr. Ahn,
length.
because of my flight is, I have to catch the flight, so I leave that chairman to Michael for the subsequent your procedure.
38?
Okay?
38 주세요. 네, 네.
Me too. Michael, it's yours.
3.3.5. 네. So another 3.5 or 38 stand. So if we do the, if we make a good coaxial and do the pre-region modification, so we always trying to use the jockey guided catheter instead of other strong backup guiding catheter. Okay. Overlapped. Test. To protrude here. overlapp했지?
예, 지금 2mm.
Test. Okay. Do you think is it good?
Yes.
Test. Okay. Inflation. 10.
10.
Deflation. Okay. That's 12.
luminite.
Deflation. Fourteen.
3.63.
Deflation. It takes time. Okay. So I'd like to see the angel first and then do IVUS. Ready? Okay. I love this angel.
Dr. Ahn?
Yeah.
There was a left main eccentric stenosis and protruding calcified plaque at the proximal LAD in the pre-IVUS. So
Yes.
I'd like to ask, did you touch the left main ostium and the proximal LAD with the rotablation or NC balloon?
I already did the rotablator for the left main ostium and then LAD ostium, but the lumen is so big, so I don't think there is a rotablation effective on the LAD ostium and left main ostium. So I'd like to use a high pressure balloon after stent implantation. I'd like to expand further. Here is the left main ostium. Can you see? Yes, this is very nice osteal stenting.
You have a couple of stunt struts, so you cover the ostium. It looks
Yeah.
good.
So I'd like to do manual pullback. Okay, distal 2.5. It looks so good. And pullback. Actually, here we need 3 or something. And the left main, definitely we need 4 or 3.5. From the so I'd like to do high pressure first for the left main. Left main, we need 4. Yeah. 4 yes. For high pressure. So let us say the for high pressure can be very expanded.
A couple of thoughts. I mean, some of the panelists thought that perhaps IVL would be necessary, but I think if you do atherectomy followed by a high pressure inflation with the NC balloon, you could get very good results.
Yeah. This is the 4O high pressure balloon. 10.
10.
Deflation. Test please. 10.
10.
12, 13, 14,
14.
16,
16.
18,
18.
20.
20.
Yes, there is no indentation, deflation. So we can engage more. Okay, 10,
10.
12,
12.
13, 14,
14.
16, 18,
16. 18.
deflation. Okay. 2.5, please.
Dr. Ahn, why you use a 4O very long balloon in left main? Do you have any reason for that?
Usually the shorter balloon would be better than long balloon. So I agree with your opinion. The shorter balloon is more effective to apply the high pressure. But it's kind of habit. So 10, this is 2.5. I don't like to touch the distal end. 20.
20.
Deflation. There is no indentation. 20.
20.
So 24.
24.
Deflation. So the guiding catheter engaged to left main, but the pressure is not damped. 24. 28.
28.
Deflation. 28.
28.
I think here we need deflation 3.0. Deflation. So almost done. After the high pressure to the LAD, and then I'd like to check the angio, and then we'll come to the last case. Okay, 10, 12, 13, 14.
14.
We have to carefully watch the balloon deflation. Balloon is very expanded, no indentation. 14,
14.
16, 18,
18.
20,
20.
24.
24.
Deflation. Okay. Ready?
It's perfection as usual.
Yes, no. So after IVUS evaluation, I'd like to finish my procedure. This is a left main ostium, very expanded relatively. Some elliptical, but the lumen looks fine. Okay, good. So this time I'd like the perfect speed is 1 millimeter per sec. So small vessel, relatively small stand, but the expansion would be good. Looks good. I applied the 2.5 up to the 28 atmosphere. Here, lumen is not that big. We can apply the high pressure here from here, I think. And definitely we need additional high pressure from here. If we have IVL, I think the stand expansion would be better after the IVL. But we don't have IVL, we only have rotabulation and high pressure balloon. So I hope I can use it in the near future.
Although there is some concern about potentially perturbing the polymer, we just don't know, have a lot of data longitudinally how it will perform. So that's just something to consider.
Okay, ostium looks very fine. So after final angio, I'd like to finish my procedure. Ready? So I think the SJ Park preparing the last case, very tough case. SJ always at the last case. So thank you very much. And then I will move to the next room.
Jung-Min, congrats. Wonderful.
Thank you.
Okay, so.
Hi, Dr. Park. It's
Hi.
Michael. Hi.
Yeah.
We hear you great.
Can you hear me?
Yes.
Oh, no. It's a long day. Today is a long day, right?
Yes.
Lateral cases, this is the last one. Actually, I would introduce Dr. Jinho Lee from he was our colleague in the Gyeonggi University Hospital. Dr. Ahn, as you know, is our senior fellow. And so we're going to do last main cases. So Dr. Ahn, you introduce that one.
Thank you. We have a 55-year-old gentleman referred for exertional chest pain. He was previously diagnosed with atrial fibrillation and coronary artery disease, and he had been treated with medication, but his symptoms did not resolve, and he was referred to our hospital. Next. He has hypertension and hyperlipidemia with atrial fibrillation. Next. The electrocardiogram showed the baseline rhythm of AFib with average heart rate of 60 beats per minute. Next. And the chest X-ray showed no signs of congestion or pulmonary edema. Next. He has normal LV systolic function. Next. His right coronary artery is normal, and the left coronary angiogram showed severe focal stenosis in left main shaft. And the circumflex artery was normal. Next. And as you can see from the cranial view, there's a severe stenosis in the left main shaft extended to the bifurcation area. Next. And this is our plan.
Great. Okay, clear. Right, this is a true bifurcation disease. Actually, for recently we've discussed a lot as we started with the main study for the bifurcation. Left main disease randomized with FFR guided and angio guided. That's what the meaning is. We really, realize that the main disease, not surgical disease anymore. So this is just kidding. It's more than 80% of cases, even in the multi-vessel disease, in our lab. So we do actually stent procedure, right? Including the supported imaging and physiology. That's a little bit different. So, all right, this is very simple but very tough remained. So, would you discuss about that? Michael Lee, but in the United States for particular these cases is, could you do PCI for that?
Oh, absolutely.
Send the patient to surgery, right?
I mean, I think this is a 10-minute case where you could do very simply. You could get the heart team involved, but honestly, I wouldn't even get the heart team involved. I would actually do it ad hoc on the table because the likelihood of any procedural or other complications is very low, and success rate and long-term durability is going to be very high. It's a mid-shaft not involving the bifurcation, so I think you're going to have excellent angiographic results.
Mm-hmm. So what I mean is your team, the heart team discussion. So which one would you do PCI or surgery?
100%
After heart team
PCI.
discussion, right?
I would have the heart team discussion just for formality, but I would still do PCI on the table and not take the patient
On the
off.
table. All right, great. Anyway, okay. So actually, we randomized with the FFR guided, function guided, and actually it's very tight. However, so Captain and you explained the FFR and obvious finding, and how would you do that for particular disease?
Yeah.
Captain, explain that.
Yeah. Firstly, I'm very honorable in standing in live case with Seung-Jung Park and greatest moderating panelist. We checked the FFR with the two branch LAD and circumflex artery. And could you show the FFR result?
All right.
We first checked the FFR with the LAD to left main. This IFL value is 0.84, and with the hyperemia, after the FFR value is 0.58.
All right.
And we double checked for the circumflex. Circumflex artery showed looking for normal, excluded the left main, but IFL showed 0.91.
Will you show the FFR?
Can you show the FFL values?
FFL to the auditorium?
Yeah.
Number?
FFL in the left circumdistal, and this hyperemia is 0.60, 85, and full step up in the just left main procedure. So we do the IVUS on the two LAD and circumflex. And could you show the IVUS imaging?
Great. IVUS.
Yeah, this is LAD to left main IVUS.
Let's just play. No, let's just play distal. Yeah, perfect.
Yeah, this is medial LAD and plaque start with
big vessels, right?
Yes.
Almost more than 4.
Over 405. And this is proximal LAD and
very proximal. Stereo plaque. Or circumflex take off from the stereo plaque, right?
Yeah, this is distal left main, very looking like soft plaque. And
very tight stenosis, right? Large plaque burdens, and also part of the main is quite good. And so would you measure the lumen areas in terms of main? Okay.
This is a minimal lumen area of the distal left main is 2.64. It's very tight lesion.
Very tight stenosis. However, plaque characteristics is a relatively soft one,
Yes.
so not too much calcium, so no calcium at all. So why don't you do that? From the panel, is there any suggestion for direct stent or something?
Any panelists would like to give their opinions?
I think this is not a mixture of left main lesion, probably including the bifurcation. I think we can do both two stent or one stent technique. For me, I think we have a FFR. I will do the provisional stent to the LAD, and then we may check the FFR in circumflex and do the kissing balloon. Try to use minimal stent as minimal as we can.
Great. It looks, it looks like a true bifurcation disease. And so, all right, we're gonna show this, circumflex obstacle.
If there is no significant region on the left circumflex osteum, in my opinion, left main to proximal LAD stenting would be better.
All right, I didn't show that, just, you discussed, this is circumflex osteum, very osteum, the big vessels, almost 4, minimal plaque, lumen area is great, not too much disease, and so, okay, Dr. Lee, what would you do there?
Yeah, the soft plaque, but dialysis 10, when we do the dialysis 10, we cannot see the distal part of the stent, so we do the pre-dilation with the 3.0 balloon. We already done 3.0.
Show me that one.
Yeah, show me the balloon. Next.
This is after the balloon, that one? Okay,
Yes.
good. Much better? 3.0.
Yeah, this is a pre-dilation after
Compliant balloon.
Yeah,
And
compliant
then
balloon.
we're gonna do, without hesitations, we're gonna do just a stent crossover. The meaning is circumflex osteum is, by Irish findings is normal. All right, so what size by Irish? Would you suggest that one? 4?
Dr. Ba, this is Myeong-Ho. I have some question. In this case, is the proximal and distal lumen diameter is relatively not so different. But in the case of the distal LAD diameter is small, we inevitably long stent from proximal LAD to the left main. How about the stent size?
Okay, pull the out just for the osteal part. Okay. Pull the out. Just good. I think we just stand close. So look, another area view, area cover or something.
Is that a 4028?
Yes.
All right. Stand wise, Onyx. Test. All right. Okay. Test again. Okay, I think it may be better, right? I want to cover the region and the osteal main too. Okay. All right. Inflation. Okay. Just to fix the fasting. All right. Perfect. No, just the nominal, for the ADD, folks, and deflate, and then through the balloon out. Further, a little bit further. Okay, I think it's good, right? All right.
That is great technique. I saw that you used your left hand to disengage the guide to prevent it from perturbing the stent, so well done.
So we deployed a 4 almost matched with the proximal LAD vessel size, and so maybe we need a bigger balloon dilation. However, all right, why not? Take a picture, just show. All right, and you first, and then okay, why not? Just after nominal pressure, the circumflex osteal part is perfect, and so we don't worry about that one. And so, what did you do there? NC balloon for 5 force, the word, I was okay. Why not? We have to confirm that one.
So Dr. Park, when you're doing these type of left mains, do you like to keep a wire down the circumflex?
All right, just before, anyways, after IVUS, we're gonna remove the wire, and then so we're gonna do high pressure. All right. Distal? All right. Just a distal landing, maybe here, right? I think it's perfect, right? thereafter. Sidewise, with nominal, pressure for onyx, evenly expanded, circumflex hosting coming in, main is still big vessel. However, stand position is good, right? Ostial part just 1 millimeter, less than 1 millimeter is hanging out. I think it's perfect. All right, so 4-5? 4-5. All right. NC balloon. Okay. All right, before that, wire out from the circumference slowly. Take the wire out. Circumflex wire. Yeah, perfect. And then the balloon main area is all right. A little bit further. Okay, good. Guiding. All right, test them.
S는 좀더 나가는
Test.
네, 그 정도 먼저 하고
Test, please.
테스트.
All right, pull out. Pull out the balloon. Okay, perfect. All right. Rotation. Complete. NC balloon, 4.5, 15 millimeters.
Yes.
All right, so nominal 12 and 16.
16.58.
I think it's good enough. All right, a little bit long duration in play. Okay, deflate.
What is diameter of the balloon? 4.5?
5, yeah, 4.5.
좀더 나와서 한번 해.
네, 여기서
But
high pressure.
actually the left main is 5 millimeter.
Yes, almost 5, more than 5. Big vessel.
20,
18, 20.
22, 24,
Okay, high pressure.
26.
Final balloon,
Inflation.
4.8. Final balloon diameter is 4.8 millimeters. It's big enough. I think it's big enough. Balloon out and okay. Picture. The arms first? Okay, why not? So we're gonna. So what changes? How much changes? Okay, that's good. Okay, leave it alone. I was from the LED. All right, perfect. This is the landing. Full expansion. All right. Wait here. Floor, please. Floor. That's almost the many, right? All right. That sounds good, right? All right. This is 4.5 for final, optimizations up to the 28 atmospheres and almost 4.8 millimeters final balloon diameter. So as you see, effective standing area. Would you measure that one? All right. It's big enough. However, just gonna fall. Why not? Over here. So take a picture and
ready.
I think it's perfect. Did you see that the circumflex hosting? So we're gonna expect that one, normal looking circumflex hosting. Would you take a picture of the spider view? 15. Pictures. All right. All right, that is final.
Looks great. I mean, one can make the argument that if you want to go with a 5.0 NC, but I still think you're going to be fine. But yeah.
All right. So actually, starting at age 15, more than 15 millimeter scale is based on our data, Dr. Ahn's data. Maybe 5-year TLR rate almost 0%.
Yeah.
0%. It's not 2%, 0%. The reason why it's big enough, starting. Actually, they still find out. You satisfied that one?
Yes.
All right, great. Okay, anyways, I hope you all enjoy our meeting as we prepare lots of issues, to discuss with you all and our family, the Caleb and Bob, all about Ahn is wife. So, you want to say next year's meeting, TCTAP 30
years anniversary. Don't miss it out. And the next year, 30 years anniversary, our TCTAP. We prepared a lot of things, and I hope everyone participate our TCTAP next year. Really enjoy the K culture, K-pop, and if you would like to see the Blackpink or BTS, come to here.
What about the Roja?
Okay, we invite her.
It's just kidding, right? Anyways, really thank you for joining us, and this is final case. We want to see next year's, with more good programs, good content.
Thank you.
Thank you.
Congratulations. Thank you so much.
Great.
Yeah.
All right.